Boom. All right. I'm sure more people will trickle in, but I don't want to keep stalling. So, Mike, thanks for being able to do this, man. Would you mind? I'm pretty sure everyone in here knows who you are, but could you give a brief intro on yourself and then the new position you have as well?
Oh, sure. So I'm a chiropractor in Harrisonburg, Virginia. I own a clinic called Shenandoah Valley Performance Clinic. Finishing up my sixth year in practice now. I didn't put myself in these silos, but where people tend to think about me for specialties would be persistent pain scenarios. So the folks who are dealing with pain-based experiences that last past that arbitrary 90 days time point, and then athletes who are trying to return to sports, so some level of physical activity. And I use the word athlete quite loosely to mean anyone who engages in regular physical activity. I also work remotely for Barbell Medicine's pain and rehab division, doing remote consultations with folks throughout the world who are dealing with pain and injury, trying to get back to the activity. And then I just started a visiting assistant professor position for Bridgewater College's Health and Human Sciences, where I teach a variety of courses from graduate athletic training classes to sports nutrition, fitness assessment, and an introductory class. And also going to do some research specifically on persistent pain issues.
Perfect. How far away is Bridgewater?
From Harrisonburg, it's super close. It takes me it depends on traffic. If it's a busy morning, I probably could be there in 20 minutes. Um, Harrisonburg is interesting because we have it by definition is a college university town. So we have James Madison University, we have Eastern Mennonite University, we have Bridgewater College, we have Blue Ridge Community College, and then only a short drive, 40 minutes south of us is University of Virginia, and 45 minutes north of us is Shenandoah University. So we're pretty much inundated with like colleges and universities in this area.
Was there a reason you looked at Bridgewater in particular? Did you already have connections there?
Yeah, so I've taught adjunct in some capacity or as a graduate assistant since my master's program at University of South Carolina. I started teaching for their phys ed department in 2009, give or take. And then when I relocated after my doctorate to Harrisonburg, I taught adjunct for James Madison University. And then I also taught adjunct for Bridgewater College last semester. And a close friend of mine, Kyle Kelleran, Dr. Kelleran, was in the position I'm currently in. He and I actually did a research study in 2018 together. He was relocating and this position came open. And, in essence, it was an opportunity that I didn't want to let go past me.
Nice. Sweet. So I read your article a week or two ago when it initially came out, and you're down to be able to chat about it today. Do you want to talk about why you decided to create it? Because I feel like obviously there's
Yeah.
been multiple like discussions on a similar topic through like the podcast and through other platforms. So what was like the impetus to create this one in particular?
Yeah, I was trying to think back because this was actually written and released in our monthly review, which at the time you had to subscribe to. And I think it was July of last year is when it was released, which means I was probably writing it May or June, which was the middle of the pandemic. So I imagine there was, some level of influence about the spread of misinformation as it relates to COVID-19, which I elected to not speak on too much in that article. I briefly mentioned it. But then also there were a lot of interesting discussions on like Twitter that I recall getting sucked into on the topic of evidence-based practice. And so I was getting quite frustrated in what I perceived to be a bit of a bastardization of the topic. And it hadn't been the first time that I got sucked into those discussions. Like I've watched EBP kind of get butchered as a discussion multiple times since I've been in practice. And so I was like, you know what, I'll just sit down and like put pen to paper. It ultimately was like a evolutionary piece because I started teaching about evidence-based practice with Derek Miles through our seminars that we started in 2017. So I already had like a lot of the fundamentals on like logical fallacies and cognitive biases. And so then I just kind of evolved that material since then.
Sweet. Did you want to give an outline of the article itself? I know it's big
Oh
boy.
gosh.
Or do you
Let me,
just want to open it up to the floor?
I can, I just like need to pull it up because it's been a little bit. Um, if I recall correctly, I talk about my own kind of like beliefs and misinformation throughout the years, specifically to like the health and fitness and then the pain and rehab world. So it's kind of like how my beliefs shifted over time, especially as I gained new information. You know, that's our hope for all human beings, but especially clinicians, because, you know, we're directly influencing other people's beliefs, not just our own. And so that's where this idea of like epistemic responsibility comes out of it, right? Like ensuring that I'm responsible enough to check the validity of the information I'm sharing with others, and then specifically in clinical practice, the information I'm giving them about the situation they find themselves in, the recommended management strategies, prognosis, so on and so forth. And so it kind of bleeds into this idea of like, well, what is evidence-based practice? To me, I try to minimize my cynicism, but in today's like social media world, it almost seems like it's this tagline to say I'm EBP. And what I've found when I talk to people about what they mean by evidence-based practice, a lot of people don't know the history of like how EBP actually came out in the 90s with the evidence-based medicines working group. And then kind of what was the premise, what were the definitions, and then how were we supposed to start integrating research evidence into clinical practice? Like, why did this happen? And interesting enough, oftentimes what I anecdotally see, the clinicians who are claiming EBP on social media are doing so to support kind of their own bias about what they think we should be doing in practice, but they don't really understand like levels of evidence and how we substantiate our confidence and level of confidence in the things we're saying. So it goes through all of that, and then it goes through logical fallacies and cognitive biases. My caveat to that is the other thing that happens on social media, and I've done this as well, is, you know, using it as I got you moments with other people that like your interlocutor that you're having a conversation with. Now I don't recommend that, and it's pretty rare you're going to see me like specifically name a logical fallacy or cognitive bias when I'm in a discussion with someone, because to me it's quite condescending, but it also like detracts away from the whole point of the conversation. Is we're trying to see what each other believe, and then probably on some level shift each other's belief system. And so just being like, I got you in something, you idiot, that's not going to go over well. I don't recommend it. You know, if you talked to me to like 5 to 10 years ago, I would have probably gone that path myself. So hopefully we're kind of learning as we go.
I know, I think the last one, the last shift you noted in the article was like in 2015, the pain output of the brain. Is there like within the like past year and a half since the pandemic started, and it doesn't have to be COVID related, but just like that's a good time frame to look at. Has there been a shift in your thought process in anything in particular?
Specific to pain or just anything?
Just anything.
That's a good question. I feel like I'm regularly questioning myself, so it's hard to like pin down one thing. I would say like, oh, an easy example was like, so in our barbell medicine Facebook group, we have a pretty sizable number of members. I think we're at like 11,000. And someone the other day was like, hey, what are you guys' opinions on percussion instruments? And I know for a fact my answer that I gave would have been very different, say 5 years ago. And I said, hey, you know, it really comes down to why you want to use a percussion instrument on yourself. If it's because you just feel like it feels good and you have expendable income to go spend some money on this item, as opposed to like paying your electric bill or something, then cool, go for it. You know, just if it shifts into I'm going to buy this percussion device for these very specific claims, then I'm going to want to see data for that, right? But I have minimal issue with someone going to get one from themselves, using it on themselves. I start getting a little bit questioning the idea of someone's paying a clinician to do that to them, or they're being sold some narrative to validate, you know, the use of a percussion instrument. But I feel like 5 years ago, I would have been like, no, that's bullshit, don't buy it. So that's certainly something that I've kind of shifted my thought process on.
Percussion instrument meaning like a massage gun or like an actual
Yeah, like Theragun is like the umbrella term for those items.
Got it. I had so I know you're into the like the street epistemology, Anthony Bot.
Mhm.
Well, probably as a whole, but like I'm assuming you watch Anthony's videos the most. And it's funny because he probably lives like 5 or 10 minutes from where my campus is located. And like the
Yeah.
campus that that he like does his stuff at is very close to like where I am in San Antonio, or where I was. And I reached out to him to ask like, hey, if I could just like sit down and grab coffee with you. I'm like fascinated by your kind of thought process and what you do. And I'd be curious to hear your thoughts about how to tackle that from like a conversation with professor standpoint. And unfortunately, he just sent a like quick response, like, I'm too busy, sorry. But I'm
Not
curious.
surprised.
Yeah, I'm curious if like how you use or how you like incorporate that into conversations with patients, or is it more so from like a standpoint of looking at it with uh interactions with like other clinicians?
As far as like challenging beliefs,
Yeah.
yeah. So that's also something I've shifted my approach on over the years. Like first year out into clinical practice, I would have thought like everything's equally important that I try to address and discuss with patients. And now I'm much more like I try to prioritize discussion points of what I think is probably the most impactful thing for them. And so a lot of that's just me asking open-ended questions about their belief system in some shape, form, or fashion that is relatable to them and where they're at with the process. And so just trying to figure out, like, if you think you have low back pain, I'm like, well, why do you think this is occurring? Or what have you been told previously about these scenarios? What do you think needs to be done? And it could be something as simple as like, oh, my PT or my chiro told me I have a lug length discrepancy, or my MD told me this. I'm like, well, that's interesting. Like, do you want me to take a look? And they're like, yeah. I'm like, cool, I don't mind doing that. And sure, I would say probabilistically 80% of the time you're going to find an LLD on someone because it's just a highly prevalent anatomical finding. So yeah, you have this, but this doesn't then mean like something's wrong with you, or you're broken, or you're guaranteed low back pain, or we need to shim a shoe or give you inserts or $400 orthotics. It's just like, you're 45, odds are this LLD has been there for a very long time. Unless you're like post-op THA, then we don't really need to worry about this. So it's working through that rather than just being like, yeah, that's bullshit, right? Which is the easy response. Instead, it's like trying to ask them open-ended questions, and then we come to the conclusion that potentially is most beneficial for them and managing and dealing with their issue over time.
Yeah, I think that's I'm just gonna jump in real quick. I think that that's kind of interesting. Like when you have the graph where it's like existence, risk, assessment, interventions, and then the healthcare professional. Um, like just reading through it, like we can have all these discussions in like Zoom and get in depth. But I kind of, I mean, I'm in my third year of PT school. I feel like it's kind of hard to have these conversations with some patients, not necessarily like figuring out what their beliefs are. I think like some very pointed questions like, what do you think is going on? I've like had some success with that.
Yeah.
But then I feel like going back to that whole range of what potentially intervention would look like they go from existence, like, okay, an elevated first rib, like it could happen. And then they jump to like, it's really hard for me to like go from it's possible and then explain like you have to get hit by, something ridiculous. And then they go straight to treatment.
Yeah.
I think this, that theme kept popping up in my mind, like as we are going through, or we read the paper together. Like as I read the paper, like how to get this more accessible in like how we're reasoning in front of a patient. Does that make sense?
Yeah. So your third year, have you done clinical rotations yet?
Yeah, so
How many?
I'm in my second one right now. And
Okay.
it's kind of like a headache, neck pain clinic. With a lot of like concussions as well in there.
How do those discussions unfold with those patients currently?
Yeah, that's a great question. Um, I think in this particular clinic, I don't necessarily say like what do you think is going on necessarily, because I feel like it's almost like um I try to like sift that out through the conversation. Like if they're on the line of like wear and tear, and I've obviously been torn through like some damage or some incident, and that sort of like started this flare up. Um, and I mean, some of these patients have maybe had headaches, like concussive symptoms, neck pain for like years. So I feel like going with the what do you think's going on? It's like they're already slightly irritated, so it's like I got my head knocked, you idiot, is kind of what I try to avoid.
Yeah. So I would encourage you to push into those conversations, right? Like the only way you're going to get better at having difficult conversations with patients is having difficult conversations with patients. And so sometimes you may feel as though you're asking a fairly redundant question, but my response usually to them is like, yeah, but I'm consulting with you for the very first time. I've not heard your story. So please take as much time as you need. Tell me what's happened and what's been going on. And most of the time they feel validated. It's not a, you're an idiot, why are you asking me redundant questions? It's, wow, this person's listening to me, which doesn't happen in our healthcare system typically. And then as you go through that process, eventually you will arrive at treatment because that's why they're there to see you. And so you can say things like, yeah, and what have you had done previously? Did you feel like that helped you? Why do we feel like that helped you? What are you looking for today? What are your expectations? I ask expectation questions all of the time. I think the hard part for students is like, especially when you're new to these types of conversations, is you need to be relatable to the person you're working with before you get into these in-depth questions. So like I spend the first 5 to 10 minutes of new patient consults just talking to them about life that has literally nothing to do with why they're there to see me. And it's just like, oh, what do you do for a living? Where are you from? So on and so forth. And I try to find common ground first. Like, oh, that's cool. Your kid goes to so-and-so school. I know so-and-so over there, or I've talked to so-and-so. I've worked with their athletes over there. I find some sort of common ground. So we find relatability with one another before I start getting into difficult conversations and like jumping in, which takes effort and slowing yourself down, right? Instead of worrying about, let me get to my objective, let me do my phys exam, let me find a diagnosis, let me do a treatment. It's like, let me just slow myself down and talk to this human being in front of me who needs help. And then as you go through that and you build rapport, you can challenge those treatment expectations much easier. So like most patient expectations are coming from a couple of places as it relates to a clinician and for their interventions, right? It's going to be healthcare professionals first and foremost are setting the stage for expectations of the clinician. Like I'm seeing so-and-so title, so they're here to help me with X. And then the type of intervention that they think is necessary. And then internet and social cultural influences are going to be the next thing. But if you don't start now with having difficult, sometimes confrontational conversations with patients to shift those expectations, then all that cool research we're reading about this should be the biopsychosocial approach to clinical practice, we should be doing X, Y, and Z. We're never going to, for my least favorite phrase, bridge that gap from the research world to clinical practice. Like it's on us to shift expectations. So you have to get good at having these conversations. I understand you guys get constrained a little bit at rotations based on like your preceptor and what they let you do though. Does that answer your question?
Yeah, that does. Yeah, I think like really building that rapport sort of gives you like the leverage down the road to sort of like when they've got certain beliefs as far as like treatment goes and what they expect, what treatment's going to look like and what the outcomes of that are. Like if you've already built up, and having sort of that refreshing conversation of like, hey, let me hear your full story, can kind of give you some like better leverage on them sharing with you, and then them like respecting, what we're trying to, that we're on the same page, like we're trying to achieve their goals.
Yeah. The way I look at it is you're their advocate, right? Like that's what you're there to do, is to help them. And so my kind of mantra to them is like, I'm going to do everything I can to help you, but we're going to do it based on like what we know we should be doing with your situation. Once you have that trust, like you also have to remember eventually you'll have the doctor title, and people are specifically coming to you because you have this subset of knowledge that they think you can provide them. but it's like anything, like I don't really know you that well, Kevin, right? So like if you told me you held X belief and I thought to myself, I'm like, man, that's stupid. And I came out and said that, or I didn't take time to get to know you and build rapport with you, I would never change your mind, right? I'm not going to change my enemy's mind. But if I sat down and we got to know one another and we built therapeutic alliance, then odds of me challenging a belief that you hold are a lot greater that I can have an influence on you. Does that make sense?
Yeah.
Kevin, do
Yeah.
they teach like the FORM method for like kind of building a therapeutic alliance? It's kind of, you talk over family, occupation, recreation, and then what the meaning of whatever this is to them, right? And it's just a standard kind of general conversation framework in which you can kind of build some of that therapeutic alliance before you start getting into things. And so you just cover those basics, right? And you can do that naturally in a conversation. You don't have to go, hey, what's your family like? What's this? It gets you into some of their social situations, get you into some of their other stuff so you can understand the context in which this person is living in and what this means in their environment as far as recreation, occupation, and family and how it's impacting all those things. And it's a great way to start that conversation. But you can, like Michael said, just have a normal conversation, but you get into some of those kind of things. And that FORM method just kind of gets you into a starting place for that therapeutic alliance.
Yeah. Do you guys have to read like a motivational interviewing textbook or anything? Have you guys heard of motivational interviewing?
I'll just speak on UT Health. The program Chris and I are at, we got one lecture on it.
All right, I'm gonna send you a link.
Also, Paul, I hadn't heard of the FORM method, so taking notes constantly.
So like I'm teaching a health promotions class for MAT students, Masters of Athletic Training students. And so this is one of my required texts to them specifically for this reason. Like it's a skill to communicate with another human being. And a lot of times it's really fucking hard sometimes to communicate with another human being. But if you learn the framework, like motivational interviewing, it's just like learning your PQRST, right? When you're doing your subjective, it gives you a framework to operate from, and it gives you a little more confidence in like having these conversations and working through this process. To ideally, the point is like, I usually think I'm just sitting down and having a beer with someone when I'm trying to have a subjective with them. Give me just a second. I'm pulling this book up.
I'm going to jump in super quick, Michael. I think I love what you said about, and Kevin, your point too, of like not rushing through that subjective. And it's something I really needed to hear. I'm in my second year right now, and like we are going into our first like external clinicals. It's for 6 weeks in November. And there's a lot of things kind of flying through my head of like, okay, what's it going to be like in, I guess, the real world, and how are things going to kind of conglomerate together into the real patient provider interactions and stuff. And one thing that I kind of having some anxiety about is like how long objective sections are going to take for me at first, just because I haven't done enough of like a comprehensive objective stuff yet. And so that looming anxiety, I can definitely anticipate having that as I complete my subjective to almost like get this done and get to my objective. And like make sure I do my objective stuff right. And so like that, I really needed to hear like kind of what you said of like, hey, like, I mean, what does the evidence say? The evidence says that like that is actually like very opposite of what we should be doing in the first place. And so I'm just glad that you would kind of appraise that. And I'm glad that you and Kevin really like hammered that point down, because I definitely need to hear that. And honestly, like that is evidence, if you want to say quote unquote evidence-based practice now, and like we say quote unquote bridging that gap. And that honestly may even lend into having some tough conversations with CIs as well of like, hey, like, and honestly, motivational interview, like, do you think it's better to have a super comprehensive subjective or super comprehensive objective, even though it's kind of a false dichotomy, like maybe even going that route was something I could see myself doing.
Yeah. What year did you say you were?
Second year. I'm in my second year, and I'm in the fall of that. So like 1/3 of the way through second year.
Yeah. So there's a couple of things there. I would encourage you. So right now, like you guys are in the thick of it with schooling, right? And so like objective, unfortunately, gets prioritized the most, and typically because of like boards, so on and so forth. So it's like learn your orthos, learn your neuros, stuff like that. Um, I can tell you, like, since I've been in practice, for me, my subjective has always been longer than my objective. And most of that is because once you get out in school, you realize, like, especially, and it's going to depend on your setting, right? But if you're like me and in what's considered like an outpatient sports med ortho style clinic, there are only a couple of things that are going to pop up on my radar that give me a nudge probabilistically to want to investigate further or make a referral. And so, like, if it's an acute onset low back pain case or even persistent, there's only about 1 to 4% of cases that are dealing with something that I need to investigate or refer, or we're not going to get the outcomes we're looking for. And the only reason I know that, and this is the entire argument for evidence-based practice, is you got to read the research on these things. And so then you would know, like, okay, what is a subjective telling me? Because that ultimately is going to get combined with your objective to lean into positive likelihood ratios and negative likelihood ratios. So, like, a bit of Bayesian thinking, like, here are my priors before I even talk to someone. And then as I'm talking to them, my priors are getting updated, and my likelihood, let's say this is like imaging that I want to order, is either getting increased towards wanting to do it or decreased, right? So then you have like probabilistic thinking, and that's ultimately how we want clinicians to operate from. There's only a couple of things that would increase that likelihood of me wanting to order imaging, and it would be, you know, if I'm talking to a 65-year-old who was like, I was climbing my ladder to clean my gutters, slipped off the ladder, fell, yeah, you're probably getting some imaging. I have an acute trauma, you're of an age where I could be worried about osteoporosis, and now I need to make sure we don't have an unstable fracture. But if we're not in that scenario, then the next question is, like, are you dealing with any type of potential cancer related issue or metastasis? So it's like, do you have a prior history of prostate and breast cancer? Do you have a prior history of lung cancer? Do you have unintentional recent weight loss? And we're not talking about like 1 or 2 pounds of fluctuation on a daily basis. We're talking 8 to 10% of body weight within a month or two, like a huge drop in body weight, right? Then I'm worried about, I need to rule out cancer in this regard. The other scenario, which you will rarely ever see in outpatient clinics, would be osteomyelitis or a spinal infection that's spread. If you were talking to my colleague, Dr. Baraki, who's an internist in Texas, he sees those cases constantly when we talk about them. But he also will fully admit his context is unicorns. Like, that's what you see as a hospitalist, is all the 1 to 4% of cases we're talking about. And then the other one would be that they're having progressive neurological symptom presentation. So, like, you consult on day 1, and then maybe they have some numbness and tingling in their L4 dermatome. And then 2 weeks later, after you've started maybe proactivity as far as like getting them active and doing things, educating, you hear that they say, hey, it's progressed to my foot, and now I have foot drops, so the foot's slapping the floor. That's progressive neurological symptoms. Maybe they admit that, hey, I'm having a little bit of leakage throughout the day uncontrollably, stuff like that. So now cauda equina syndrome. Then you're going to image or refer. Those are 1 to 4% of cases. The majority of cases you guys are going to see in like outpatient settings aren't going to fall there. And so my like baseline concern for most cases I'm consulting on is extremely low. And then I've just got to listen to what they're saying to me, which is technically a part of your objective exam. Like, you're taking all that information in, and it's either going to increase or decrease your likelihood for wanting to do something. And then my objective is looking at the area, checking range of motion. I don't think much of orthos, which is a whole conversation we could have later, mostly because their sensitivity and specificity and their ability to affect positive and negative likelihood is not great, right? And we have studies on like not able to correlate what we do on an ortho, the positivity or negativity of it, and correlating it to imaging. So I'm not a huge fan of orthos, but it doesn't matter what I think. What matters is what the boards thinks currently. And so you have to learn that stuff. You have to go through those steps, and then your neuro exam. Does that help? Does that make sense?
Yep, definitely.
Yeah, so you're learning all sorts of stuff from your subjective. You should be. And I'm not even, at this point, I'm not asking, you know, on a scale of 1 to 10, can you rate your pain for me? Can you, yeah, so on and so forth. I'm just having a conversation with them openly and gaining the information that I need to make informed decisions.
Yep. And it's funny because like we have a big skills check coming up in a week or so. And we were going over with one of our ortho profs, and she's awesome. But she was just like, let's give it like a bonus question with like sensitivity and specificity, and it's like, which is the best test for a meniscal tear? And I would think this snarky butthole I am, I was like, a comprehensive subjective exam. And she was like, well, actually, you're right. And like the more tools I get thrown at me, like as I continue my journey through school, the more I realize that there's so many, like, you can't like use everything, and you can't feel like you need to know and use everything every day of, or through every patient. Like you've got to be selective
Yeah.
with the person in front of you, and you got to funnel stuff down. And that comes to experience, which I obviously need more of. And it's cool because it's like,
Okay.
wow, it's going to be a great journey. And really a journey that never ends in clinical expertise. As I look up to guys like you. So
Yeah. I mean, the fact that like you're even having these conversations, you're ahead of most folks. I promise you, especially after, getting into academia is interesting, but I would say you're ahead of most folks, just like attending a journal club and having these conversations and thinking about these things. The other part of your question I didn't want to forget about is like your CI. It's really going to be up to you guys, right? Like ultimately you have to get a grade and pass school, or you never get to the clinical side of things on your own. So another thing I changed my mind on, Chris, I would say like 5 to 10 years ago, me would have certainly argued about stuff. A friend of mine who went through my master's with me always tells a fun story about how like in the middle of a class when a professor is going over a test, a lot of people got the question wrong. And I was like, well, that was just a fucking stupid question. And the professor just like stopped dead in his tracks and just like looked at me like, I can't believe the student just said that. And he rightfully so. Like, it's not what I recommend. Today, I would say like, if you feel as though you have a good relationship with your CI and that you guys are capable of having a one-on-one conversation, I wouldn't do it in front of patients. It's just like if I'm trying to have a conversation with a prior employee or something, I wouldn't have conversations like that in front of others. It would be, hey, do you have some time to talk that we can meet, schedule it, go talk to them, and then just lay out your thought process and give them the floor to have a conversation with you. I would imagine it's going to be variable person to person. And it's also going to be very dependent on how you go about that conversation. So if you're attacking, if you're emotionally charged, it's probably not going to go well. So when I feel as though me and someone else are going to have a disagreement, I usually don't start with my opinions. I start with, hey, I noticed you did this. Like, could you tell me more about that? Is there something I could maybe read on it? And so I let them explain themselves first and then decide if I want to like poke holes in that conversation or not.
I have I'm curious to hear your thoughts about this. So I'm in the acute care setting right now, and we had a patient that was on one of those like bird scooters. She flew off and
Oh gosh.
really just fucked herself up really badly. And she was only in for like a week, and now she's discharged to inpatient rehab. But she was just, when we stood her up off bed, she like was complaining of like just intense like gluteal pain, and she was unconscious when she hits the ground, so she didn't know how she fell. But I was like, my potential guess is that your hips are sore because you probably landed really hard on your hips. And then she was just like in excruciating pain. She had to lay back down, and my CI was like, do you want to try like some long axis traction on her? And it's like, or I think that's what it's called. I honestly like never did in the ortho setting, but I literally just like pulled her leg to create some type of relief. And it was like, would I have ever done this with a patient who was like complaining of, similar area but less severe in an outpatient setting, or would I have wanted to like ask why they were? So it was like such a different context, because it was like this girl like had a traumatic incident. She like isn't from the city. She lost her, or she like can't afford XYZ. So it was like, is there even a point to sitting down and asking why she wants to do the thing? Or is it like, is in this instance, short-term pain relief a very valuable experience or thing? And, after the fact, she was in just as much pain. And so like, it didn't really change much, but it just made me think of like these people that are in the worst case scenario, and they just like, they want anything to make them feel better. Does that change your interpretation of like, maybe some things you wouldn't do in a longer term outpatient setting?
I'm just curious, but did she have any like pelvic fractures, or what was
No.
she was triaged, I'm assuming. So like, what were her case findings?
She had a major, or she had an MTBI. She had like a right wrist sprain. She just had a ton of like bruising on both sides of the body, but there was no like unstable fractures in any region.
So you guys are trying to see if she could ambulate for discharge or?
Yeah, we saw
Yeah.
her, we did an eval on her and then saw her 1 or 2 days after. We're just seeing, where's the best setting for her to discharge post-acute setting.
Yeah.
And it was
So
just
you-
such, go ahead.
You could have done anything though, right, to most likely get relief, even if you would have been like, hey, maybe we try to do some glute bridges, or hey, maybe we try to do some flexion and extension on that side of the leg
Yeah.
and see if you feel better, and then slowly get you, you literally could do anything, right, to get some acute symptomatic relief, even just providing reassurance as best as possible in those scenarios. I mean, sometimes you like can't force people to do things they don't want to do. So if she were like, I'm not getting out of this fucking bed, it's like, all right, well, I guess you're staying in the hospital, right? Like you gotta have some ability to negotiate with folks on some level. So you're gonna have to weight risk versus benefits in that context. But was she taking any medications at all at that point?
Yeah.
Was she taking any like pain medications at that point?
Yeah.
Yeah. So, she's already on something that's supposed to be alleviating. So there's just a lot of layers. Like I start thinking about those scenarios. But yeah, I think you could have done literally anything. So if the CI would have said like, hey, why don't you do, a little bit of distraction on her hip? Like, hey, why don't we try just to see if she could do some like flexion and extension or some straight leg raises, and then we'll get her out. See if she feels more confident with doing that lower level exercise before I make her stand and try to ambulate around the hallways, And then odds are, if you're able to be reassuring and set expectations appropriately, you probably could get that to happen. Does that answer your question?
Yeah, I agree. And I think that would provide, that's where my bias is. And,
Yeah.
but in those instances where she also has she has some extreme like anxiety and prior like
Right.
history of depression, it's like, how do you even talk to someone about, what she's trying to deal with? Or it's like,
Did you?
go ahead.
So I was just curious, so the things that I think about in the scenarios is I try to reassure folks. I'm like, hey, I understand this was a really like shitty situation that we're now all having to deal with, and specifically you're having these experiences. The good news is like there were no fractures or anything that gives me a ton of concerns identified. That means that you shouldn't do this. It's more about how do we figure out how we do this to tolerance so we can get you home, you can get back to your life, and we can kind of move past this situation. And so even just taking like 90 seconds to have that conversation, to reassure them that I understand they're in a good amount of pain. It's going to be okay. It doesn't mean we can't do anything. We just need to figure out what can we do today and build from there. You know what I mean?
Yeah, that's a really good point. And that's like, that could be a very similar conversation that you could have with a patient in the outpatient setting. So
Yeah.
it's really not.
Oh
that
yeah. Yeah.
different.
I had a guy, he was skateboarding, mid-30s, and he tried to outkick his coverage as far as his abilities on skateboarding. He had just started, tried to make a sharp turn, didn't go well, fell on outstretched arm. He had the highest grade AC separation I've seen yet. He was a 4, and they ended up having to go in and do reconstruction on his AC joint. And it was a similar scenario, like extreme anxiety and apprehension, but not only just because of like this massive trauma to the AC joint, he had to go to UVA and have surgery done and all these other things. He was worked for himself. And so now is this huge financial burden and impact. He couldn't go do his job. All of these layers were factoring into like his apprehension of wanting to do activity and engage it again. And plus it's a pandemic. So it's like, just, first session is just like sitting down and being like, yeah, man, it sucks. I'd be pissed too. Like, I get it, trying to enjoy activity, and you had this random freak accident and all of these other things had to happen afterwards. Like, sometimes it is just like sitting and listening to the human in front of you.
Thanks, man. That helps.
Yeah.
I did have a question. I've talked about this to a few students on Thursday, and I don't know if it's like a coherent question or if it makes sense, but it, like you kind of alluded to, some of this more structured evidence-based medicine started in like the 90s, early 2000s. Do you think that this is I don't know if fad's the right word, but do you think in like 50 years from now, it's going to be looked at as like, oh, this was the thing that everyone talked about, but we've moved on and this was silly? Or do you think it's such a critical and like a baseline framework for, how you conduct yourself as a healthcare provider, how you conduct research, that it's just like it can't really, like, something new can't be adopted.
I mean, I think to use an absolute here, I think there's always potential for new things to be adopted, new models, new ways of thinking. Like I maintain a pessimistic meta-induction kind of premise, which in essence is a fancy philosophical way of saying, I assume everything we currently think is either going to be partially or completely demonstrated as incorrect, right? Like that's just what history tends to show us. And that's kind of the point of like, if we're conducting science appropriately, that should be happening. So I certainly don't think like EBM, EBP is the be all end all, but I think as of right now, based on the totality of information we have, it is our best option, right? Versus just like anecdotally recommending things, basing our recommendations off of eminence-based healthcare, like my name and my title. I think it's the best way we can level the playing field with knowing what are the best recommendations. If COVID-19 taught us anything, if we don't do that, we see all sorts of claims like hydroxychloroquine should be our go-to drug for management. Vaccines aren't necessary. Like there are very, very serious consequences if we're not operating right now from an evidence-based medicine or evidence-based practice model. But I think people like Djoljevic are right, despite some of his publications during the pandemic. He wrote a paper, if you're not familiar, on evidence-based practice, has it been hijacked? And he's writing it as a letter to Sackett, who he knew when Sackett was alive. And Sackett's considered, one of the godfathers, so to speak, to evidence-based practice. And so he's basically saying like vested interests have hijacked evidence-based practice. And I had this conversation with a couple of people this week about a Twitter conversation that I got into with a Stanford researcher not wanting to like release their methodology to me on their study. And I'm not going to get into that any further, but yeah, I think there is some validity to, we have to be skeptical of the quality of evidence that's being put forth for consideration, even in evidence-based practice. And so that's why it's so important for clinicians to get good at reading research, understanding research, figuring out how does it influence their clinical practice, but being able to appraise research. If you don't learn that appraisal aspect of it, then you could easily fall prey to believing anything again and not understanding like, hey, this thing has 2 paragraphs of conflict of interest. The methodology doesn't make a lot of sense. Maybe I shouldn't look at this and weight it with high confidence that I should be doing this in clinical practice. And so that takes, just like going to the gym and doing exercises, it's just reading research on a regular basis, learning about stats, understanding why someone ran a particular analysis, and then looking at, do their interpretations and conclusions match their findings and the confidence level? You know what I mean?
Michael, I don't disagree, but I think part of this is we have a paucity of good research, right? And replicable research, and then things that we can bring into the clinic because they say, here's the standard of care. Well, what the hell is the standard of care? You won't tell me, right? And then we have this other version of, well, we did this program and it was eccentric based, but they won't even give me the exact program, what the dosing, what the thing, what the pace, all this other shit. So how do we actually implement in clinic some of the shit that's being produced? And that's a real hard thing for me because I can read evidence, right? But when it's shit across the board, how do I apply that within clinical practice?
Yeah, it's a great question. I can tell you what I did, which is I go to the first author and ask for their methodology, and then just pester the shit out of them and act annoying of why they're not publishing it. Because it is, to your point, it's a major issue. Not in just pain and rehab, but it's also a major issue in like exercise science. Like it's very rare you're going to read dosage of activity from a frequency, volume, intensity, duration standpoint, which is ridiculous. So like when I talk about, because usually people say to me, they're like, oh, well, you're against past modalities, you're against XYZ. And I'm like, no, I don't think you understand. Like the way I currently look at this is if pain is our only outcome that we're concerned with, you can do damn near anything in clinical practice and affect that quantitative metric, however we're choosing to measure that outcome. I'm not a fan of quantitative only driven research specifically on the outcome of pain because you can do damn near anything. And so I even say exercise is prey to the same validity issues. I can have placebo-like contextual effects from having someone become physically active, from setting expectations. So I kind of think about it from, how do I minimize the most amount of false beliefs and behaviors on my patients while trying to push as much self-management on them as possible, because that is what tends to be what I would assume as the best possible standard of care that we have. The article that comes to mind would be Lynn et al., who talks about I think it's titled like the 11 best practices of musculoskeletal care. And they did a review on it. It was in the BJSM, I want to say 2020 or 2019. And so like, yeah, it's hard accepting that where we want our research to be and where it's actually at leaves us in a position of like, how do I make a difference in my clinical practice? And that's why I look at, well, what are the other things we can do outside of mitigating symptoms and symptom relief? Because we know like there are a whole host of reasons you're going to get that outcome of pain reduction, whether it's natural history, regression to the mean, placebo-like contextual effects, so secondary effects that have nothing to do with the intervention. Then maybe I can facilitate better positive behaviors that are going to affect health outcomes. So what does quantity and quality of sleep look like? What does stress management look like? Do they feel supported in their life socially? Do I need to refer them to a psychiatrist or psychologist because they are having severe anxiety and depression, or they are having suicidal ideation, which I've found a lot of clinicians don't feel equipped to ask that question, like asking about, have you thought about killing yourself recently? Did you create a plan for that? Making sure you have a referral network in place to get them where they need to get further help beyond your scope of practice as part of being a clinician. So I really look at us when I talk about clinical practice, I don't talk about DCs, PTs, ATCs, MDs, DOs anymore. I talk about healthcare professionals. And so the amount of data that we have on how do you actually affect positive health outcomes, we don't have a lot of options. It's the ones I just named off. And so I think that's also where PTs especially can serve a very valid role is, what does your caloric intake look like? What does your sleep look like? What does your physical activity look like? What does your stress management look like? And do I need to refer you to anyone else? And the pain side of things is going to take care of itself over time for the most part.
Ben McCormick and I had a little round about one of his posts, which was pain focused, right? And stuff.
Yeah.
And so there's so many other things that we should be focused on. Yes, people come in generally for pain, but it's a loss of autonomy, a loss of belonging to social structure. It's a loss of my ability to create meaning in my life. That's why they're coming. The pain is a proxy for that, but it's really those things that they're coming to us for. So how do we return them to those things and let the other kind of side take part of the other stuff? Because I don't directly affect pain. Right. I mean, I really don't. I'm doing things in whatever it's contextual, whether it's this, whether it's they now have a belief system that's different, whether it's they're now actually taking positive steps. All those things can affect that. Right. So
Totally.
But I don't know how I'm directly impacting that, but I can directly help them with sleep hygiene. I can help them with some of these things. There's a lot bigger things that we can be doing, and just getting people moving to 150 minutes a week, maybe right, good enough to help most of these people that are pain basic, right? And then we have specific things, task specifics, if they have to go back to sport or they have to go to those things. Those are all the task specificities that are to that individual, and identifying those with them and helping us get back to, okay, you need to be able to do these things. This is a rate limiter for that. We're going to work on this, right? We can argue whether or not what's the best way. I'm not sure there is necessarily a best way on some of these things, because it's what they're willing to do and what, I mean, we start losing some of the research in this because that individual's not going to do what the research wants. Right.
Exactly.
You need to put 80 pounds on your back and do 3 sets of 15, 5 times a day for this eccentric loading. They're like, fuck you, I'm not going to do that. So now what do I do? Right. Exactly. So now where am I? Those are the realities of clinical practice, and how do we get there? And so that, to me, that those are the real struggles that these younger clinicians are going to be facing. I've been doing this for 26 years, and you kind of figure out what's generally working for you and how you communicate and how you relate to patients. But those are things that it's a hard road, because you have to have a lot of failures. You have to analyze those failures to make them meaningful. And then you have to be able to make the adaptations as you go forward.
Yeah, I totally agree. There's a weird straw man argument that presents, I'm going to break my rule of not naming a fallacy or a logical thinking, is people think that because you're focusing on other outcomes that you're not focusing on pain. And I'm like, it's not an either or, it's all encompassing patient-centered approach. So it's obviously inclusive of their pain experience, right? But I don't have to spend my whole time talking about after every single conversation or set, did that hurt? Do you feel better? Like, we don't want to do that, right? So I don't look at it as this mutually exclusive approach at all.
I agree. That's a false dichotomy that people say, hey, there's pain, there's this. No, this is a person that just needs to get back to doing things. And how do
Yeah.
we best approach that, right? And
Yes.
again, those things, how is their family related? How is their occupation related? How are the recreational things needing? How is this meaningful, and what things are meaningful within their world? And then how do we help them get back to those things? Because I really do believe the loss of autonomy and belonging and their loss of cause, or the loss of ability to make meaning in their world, is what they're coming to us for. How do we get
Oh,
them
yeah.
back to doing those things?
Yeah, exactly. And the totality of data on specifically like pain research, that is what it's demonstrating is people are seeking this out because they're suffering, and the suffering is directly related to this experience. And then the question becomes, well, what explanation are we going to give to them for their experience, and what beliefs are we going to foster in them, and what behaviors? And up to this point, we've done a really good job at over pathologizing, over medicalizing, selling unnecessary interventions, and creating passive coping behaviors. So now we're like, fuck, we've screwed this up for like 30 years, like, well, actually even longer, given PT field was like World War II, right? For creation, right after World War II. So it's like for decades, we've been scaffolding all these beliefs and expectations, and now we're trying to backpedal. I mean, obviously this is going to take well after I'm out of the field and gone to the next group of people coming into it.
What do you, what you talking about the overtreatment or overdiagnosis, when you like have done an initial eval with a patient, are you just providing options of explaining like, okay, this is my interpretation of combination of what you said and what I'm seeing, these are the options we can go? Do you always frame it as like, we could do nothing, you could come in once a week, we could try something for you to do at the house? Is there ever a time where you're like, how do you present it after an initial eval? Like, are you laying out multiple things?
Yeah, it depends on the individual. I think the hard part of these conversations is realizing there's no general template for the most part. Like, things tend to change individual to individual. But usually during the conversation, once I've rolled out things that would give me concern for investigations or referrals, and I know that, we're in a good position from a medical standpoint, that I don't have a lot to be concerned with, nor do they, it's figuring out what level of confidence they have in self-managing. And you usually have things that get said to you along the way of your conversation that are like, this person probably is going to need a little more guidance than others, or this person seems pretty good to go. They don't need me. I'll just tell them that if they need anything in the future, to reach out to me. And you'll kind of get a gauge for that along the way. If you're struggling with it, I tend to just ask people like, hey, how confident do you feel about self-managing through what we've discussed today? Is there anything else you need from me? Would you like to come in on a regular basis? I often turn it into a joke, because they'll usually ask me, well, how long do you think this is going to take to get better? And I'm like, well, let me consult my magic 8 ball and I'll let you know. Like, there's just individual timelines. We have some idea of like, oh, acute onset low back pain, you're probably going to see pretty substantial improvement in the subsequent weeks in your pain experience and function. If that doesn't happen and you feel like you're struggling and need a little bit of help, I'm here for you. So I always try to put the ball back in their court and push that responsibility on them, versus trying to sell them on a treatment plan or make them feel like they need me.
Chris, to answer your question, I approach it a little bit different. I still want them to have that, but I believe in marination. Some of these people need to marinate a little bit in positive feedback and in some of these thought processes, and have them go try it on their own and then come back and we have discussions about that, so that they can kind of get some walkthrough through that, rather than them having to call and say, hey, I failed at whatever, right? I just have it already on the book, so that they're coming in, so that we have that discussion. So it's not the impetus on them to have to come in and admit that they couldn't do that, right? So they're already scheduled, so they're on there, so I can marinate them a little bit more in the coaching and some of that process, and then they can kind of go out on their own. So I like that marination idea. Just, they're going to get the flavor of what I am and what I'm believing over time, and so they need some repetitions with me over time, and then we space those out, and then they go out on their own.
Totally. I think that's perfectly acceptable. I think too, like, if it's a post-op situation, like if I'm seeing an ACL reconstruction, very unlikely I put it off on you to be like, good luck. Right. So usually in those, when I'm setting expectations, especially for like trauma or post-op cases, and if it's like an ACL reconstruction, I'm like, we're going to be best friends, because you're going to see me like 3 times a week for the first couple of months, 2 times a week for a couple of months after that, and then 1 time, and then hopefully once a month. And maybe by 9 months, we're ready to do your own thing without me. Right. So it's just setting expectations based on context.
going back to the subjective, I'm just curious, like, because obviously you put so much weight on it. What does that look like physically with a patient? Like, are you in the, like, I know you have a clinic gym set up. Are you in there? Are you like sitting in chairs? Are they on a table?
Oh, that's a great question. A lot of people don't think about that type of stuff. So my environment is purposeful. Like I wanted it to be an atmosphere where they're like, okay, this guy's gonna make me do work. Like that expectation gets set immediately upon entering my clinic. But once we're back there, like I sit on eye level with them during my subjective, just talking to them like a human being. And then if I feel like I need to do a physical exam, I'll put them up on my table, which kind of elevates them. And then I'm working like on them. I'm not a huge fan of it because it does look at like them as an object, right? Which is an objectification of the patient. But on some level, we have to do that to be a clinician. And as soon as I'm done with my phys exam, I get them off the table, back into the chair, and I'm looking at them at eye level. Does that answer your question?
Yeah, it does.
Yeah.
Thank you. I like, so the first rotation I was at was with Amato, and he was very, I was just really impressed of how he did it. Like, it was interesting because I don't know, like, I mean, this is probably like too much, but not too much, but very in depth of like, he doesn't sit directly like facing towards them. Like he has like a table, like a plinth, whatever. And then he had a chair and he would like kind of rest his arm. And then the patient is like kind of like caddy corner. So it just felt like really chill, like casual conversation. And the patient's like, they kind of have to look one way to look at him. And then if they look straight ahead, they're just like viewing the gym and the patients and the other PTs. And I was like, I don't know if Amato is doing this on purpose, but it seems like genius.
Yeah, you should have asked him. He would have told you.
Well, I sent him a long audio message. He was like, I guess some of that I do on purpose and some of it is just like the layout of our clinic. But
I figured that's what he'd say.
Yeah, he like, then we'd go on the table and then he would sit him back down. So it seems like a similar situation that you're
Some
doing.
of that is like I think about my experiences with healthcare professionals, and me personally, I never liked just being left on the table where you're objectifying me the whole time. I would prefer to like talk to you like a human being versus, and a lot of that's going to get into like power play roles and stuff like that, and being like an authoritative figure as a clinician, and the patient seeking out your help. I read a really good paper just this past week that just came out from Canero, who I'm a big fan of. He was the one that did the lead author on The Body and Pain, which came out last year. It's excellent if you guys haven't read it. But he just released one about like what should patient-centered healthcare look like for the musculoskeletal space. It's phenomenal. It's only like 4 pages long. And he talks about this, like making the patient your equal. And I am a firm supporter of that. Like we shouldn't be viewed as this authoritarian dictator type figure in patient-clinician relationships. Like any relationship that's ever worked out for you typically is one of equality, and you have some level of autonomy involved in that relationship, and that's ideal. And so that's why I think about those things, is I don't want to make them feel as though that I'm above them or non-relatable to them on any possible level that I can control.
I fully agree. I look at it slightly different, as rather than equals, they're the expert in their experience.
Yeah.
I'm the expert in what they're coming to see me for, right?
Trying to
we
make
want our
meaning.
expertise to work on whatever the issue is that's there. So we're working together for that, because I don't know their world. I don't know how this experience is affecting them. They own that. I own my body of knowledge, and we bring those two things together to the forefront to try to solve the problem that they need solved. Right. So we're both experts. We're just experts in different things, and we're bringing that together to solve that problem.
Yep. And hopefully we don't create unnecessary issues for them with our expertise.
Right. Well, I mean, yeah. I mean, there are narratives that we can go down that can screw that up without a doubt. Right. And we need to be cognizant of those. But the reality is they own their world, right? They own that. I don't know that, and I don't understand that. So I need to be asking questions and learning that, so that I can bring my knowledge to the forebear to help with whatever it is. But they're determining what that help is. I can't put my biases and my beliefs on them. Yeah, I put everybody on a barbell if I wanted that, but the reality is that some of these people don't give a shit about handing a barbell or being able to lift weight, right? I just need to be able to function in my world, and this is what it is, right? So, okay, I've got to meet them where they are and what their needs are and what their desires are.
Totally. Yeah. It's funny because people here, I work for barbell medicine, and they're like, oh, you prescribe barbell work to everyone? I'm like, not in the slightest. And in fact, most no. Like, it's just an umbrella term for a company. But yeah, so there was another good paper about identifying facilitators and barriers to implementation of exercise and musculoskeletal care. And I think this one was specifically on low back pain. But one of the main findings were clinicians were programming therapeutic exercise that wasn't a tangible manner for the patient. And so it was like, go use this equipment. They're like, I don't have that equipment. Or go do it at this time of day. And they're like, I can't do it at that time of day. And they weren't identifying facilitators and barriers to them implementing these behavioral changes they were advocating for. And I think that's what you're talking about. Is like, you've got to meet people where they're at. You've got to identify facilitators and barriers, try to knock down those barriers as much as you can and then move forward. Ultimately, like if someone pins me down, I'm like, we're belief and behavior changers. Like, that's the crux of our job. We're addressing beliefs about their body and pain, and then we're hoping to alter their behavioral responses so they can go back to their world. And that's why you have to build that rapport and have a relationship. You're never going to influence that stuff. And I think the harder part for students is, and I came out this way, is it's like, I'm going to help everybody. There are going to be people that aren't even in like the pre-contemplation phase of the trans-theoretical model of behavior change. And you're out there like spewing all this pain science stuff to them, or talking about how you're going to get them back to activity. And they're like, I don't give a shit. I'm here because it's a workers' comp case and they sent me here. So you got to just accept, like, some people you can't help, and that's okay.
But I also believe, again, back to the marination, I may be just planting a seed, or I may be putting the first little sprinkle of things on, right? Other people may reap that reward down the way, because this person may or may not be a frequent person within the system, right? And so if we start early and hopefully they have follow-up marination that's similar, then they get to the right flavor and they're cooked appropriately and ready to go out and do the thing themselves, right? I mean, I do look at things kind of through that prism.
Totally.
It's not always me that gets to have the meal, but somebody else is. I'm just adding the first little layer of flavor, right? And so that's part of what we're trying to do sometimes, because we're not always going to make an effective change. These people need to marinate in things, think about things, ruminate on things, and figure out where this fits into their world long term. That's a different thing. Yeah. Totally. I like to cook and I like to eat, Chris. Sorry, man.
Yeah, it's interesting because I've worked with patients and students as interns and so on and so forth. And like, people will come back to me years later and say like, yeah, you said this. And I'm like, I don't even recall that, but I'm glad it was a positive impact on you. So I think I like the idea of marination that you're talking about.
Do you have a conversation or a topic that you still struggle with patients, whether it's like trying to explain what's been going on, or just to something that you feel like, oh, this is really hard to navigate? Because there was a point where I saw like 3 patients with low back pain, like Monday, Wednesday, Friday, with a motto, and I just like really stumbled over my words with like, I don't even know if you need to come, like, I don't even know what's going on. And I feel like this is going to be fine, but I can't explain. Like, I just really had a hard time wrapping up an eval with that type of individual, or presenting with that. So I'm curious, like now, currently, if you see a patient coming in, if it's a particular injury or a particular thing that they bring up, where you're like, I just struggle with these type of conversations.
Yeah, I mean, my first response to like your experience is sometimes it do be like that. Like, we're humans, you're not going to have the greatest day every single day ever. And you just got to reflect and be like, well, how could I have done this differently? It's funny, like my wife runs my clinic. If she were on this call, she could easily like recount the times that I've been like, man, I really fucked that up. And luckily, like I have a support network from her, because she's like, yeah, but you know, you'll have another shot at it, which is a great thing in our rehab world. We often do follow up with folks, or, you know, learn from it and try to do better. So I wouldn't beat yourself up over like having off days. We all have those. It's like training. Some days an RPE 8 means you're squatting 405 pounds on the bar, and sometimes it means you're getting stapled by 225. Like, it just, that's how it is, right? But yeah, there's totally topics that I struggle with. So like when I'm talking about what we think is going on in their scenario as far as an explanation, the way I approach it now and the way I approached it 5 years ago is very different. I am much more like, what's the minimal amount of information I can give and gauge their response. And so the people who want to keep throwing themselves down the rabbit hole, I have to really try to ensure I navigate my language carefully. So they're looking for this very specific diagnosis that isn't very meaningful in the management of their case. And so getting them to focus less on that, I think is hard for anyone, especially if they're very, very sold in on this is the issue, this is what needs fixed, the expectations are already set, the outcomes are probably already fucked, but it doesn't mean I'm not going to try. That's probably the hardest part of clinical practice for me currently, I think.
Michael, you won't remember this, but I shot you a DM one time on Instagram, and we were talking, it was about pain, it was about expectations and kind of that kind of stuff. But it is, for me, setting that expectation, those patients that are resistant, and we were having a discussion about why the negative influence seems to be that much greater.
Oh yeah.
Than the positive. I can tell somebody all the positives that things are going to do, and it doesn't change behavior, it doesn't change things. But as soon as I confirm a negative belief that they have, we're kind of fucked, right?
Yeah.
I mean, really, because they already have that. They have that fear, and as soon as I say that that might be possible, or that's what they link into. I could have spent 95% of the talk on good stuff, but that 5% of that confirmed whatever negative bias that they had, they tend to hang on to that and go, yeah, I'm totally fucked. I'm degenerative. I'm falling apart. I'm doing whatever. And you know, we know that there's this kind of almost primacy of this negative belief system that seems to be human, whether for whatever reason. We can go into developmental, we can go into you know, evolutionary aspects, we can go into that, but we tend to look for the negative and kind of poo-poo the positive, right?
Yeah.
And so you know, how do you work around some of that in your conversations? I'm interested. I've been doing this a long time.
Yeah.
I have my ways that I try to, but sometimes, again, we all fuck this up, and you know, and then you can walk out going, you know, I always ask, so what did you take away from this? Or what did, you know, what was the good thing that happened? I try to ask, what was the good thing that you took away from this? And sometimes I get no answer of good things. They just kind of, well, yeah, I'm fucked. I'm old, I'm broken down, and my system's not going to get over this. And you're like, I don't believe I ever said any of those words, but that's what you took away from today's session. Okay, I got a lot of work to do on this. So how do you work around some of this?
Yeah, well, A, I've said things where I'm like, I wish I could take that back. Like, I knew I negatively influenced the case, and there's nothing I can do. Like, the words are out there, it's done. They latched onto it. And so my hope then is like, in future sessions, I can backpedal away from that so we can rebuild and move on. Sometimes it doesn't work, unfortunately. But it's just having continued conversations in my mind of like trying to work through that. And I think your example of like asking them to say, what did you hear me say? Kind of get them to recap their takeaway from the consultation or from that particular session is a great way to go about seeing their level of learning and what is their understanding, what are they perceiving from your conversations together, which may mean that I need to alter the way I'm delivering my information or the way I'm trying to relate to them, because I don't feel as though it's tracking the way I would like to see it. So you have to be willing to do that. But if you didn't ask that question, you would never know, right? So I think that's a great approach.
I think, oh, go for it, Michael.
Sorry, I just wanted to jump in. So I was just my perspective, someone who's been practicing for a year now in a PT clinic. Just yesterday, I had someone who had, has made great progress and is able to play basketball for like 3 hours, playing better than he's ever played. And then still saying like, having these negative ideas and like, oh, there's so much degradation in my glute and this and that. Thankfully, I had the rapport to kind of jump in and say like, what are you talking about? Yeah, you're playing basketball 3 times a week, and like, you're so much more resilient than this idea. So in that instance, just having that rapport to jump in on those negative beliefs and kind of let's try to shift the focus as soon as possible. But yeah, no, I totally see sometimes like those negative beliefs persist, even when someone can say like, yeah, I'm really strong, I'm feeling so much stronger, and then there's still this kind of, maybe it's just societal, but that kind of structural belief, or that's just sort of ingrained in them almost.
So like the paper that comes to mind is Bad is More Powerful Than Good. I'm blanking on the lead author's name, but it talks about like the nocebo effect and so on and so forth. But yeah, I think it's really hard to feel as though you can help someone. Like you have the skill set, you have the knowledge, you have the abilities, you have the opportunity, and you can't. And that's something that's really hard. And any clinician, all clinicians go through that. Anyone who's been an educator or tried to do anything in someone else's life from a point of helping, you have to accept that sometimes you can't help folks. What's the old line? Like, I can lead a horse to water, but I can't make them drink. Like, humans are the same way. Like, you could want it for them all day long, but it's just not the right time. To what Paul was saying, it was like, sometimes you do need to let things marinate. Sometimes 5, 10, 15, 20 years down the road, maybe they shift their beliefs. I mean, people ask me all the time, oddly, I don't know why this is a podcast question, but they were like, if you could go back, 20 years in your life and tell your younger self something, what would you say? I would say, not a damn thing, because 20, I wouldn't have listened anyway. So like, that's just how it is. Humans are gonna humans. So, but that, I get that, especially as a new clinician, that's tough to accept.
I have a question about the academia, because I didn't realize you had been in so many different universities popping around. The one you're currently at, and if you don't want to talk about it, that's fine. But I'm curious, like, your interactions with other professors, either on these type of topics, or do you feel like there's a lot of, old school mentality and older professors that you're just like, I don't even know how to have, conversations with them on these topics? Have you felt like that's been a struggle?
No, I think for, again, 5 to 10 years ago, it would have been hard, but I'm much more in like the rapport building stage right now. So like, I don't go into new scenarios and be like, I know everything, let me change the world. Like, that's not a good, like, I don't recommend that. And you probably don't know everything, and you're going to put your foot in your mouth pretty quickly. So some of it's me, like, especially like my grad students with AT and with those faculty members, it's learning, what are the expectations of an AT, which are different from a PT and DC, especially sideline work. So they are in scenarios where they're doing emergency triage. If someone goes down on the field, they're running out there to help assess. And that's a very different scenario. Like, they're not asking them about, what do you think the meaning of your pain is, right? Like, that's just not going to work on sideline work. So it's a lot of it right now is me getting my bearings, listening, absorbing, building rapport, and then challenging things that I think we probably should do a little bit differently. And up to this point, like, when I'm in meetings with fellow faculty members, when I do challenge something, they are very willing to listen, hear each other's points of view, and then figure out how we can do things better. The nice thing about this department, and in general, I think most of academia functions this way, is we realize we're there to help students. And so if we think there's something we could do differently or better collectively as a faculty, we're going to look into it and try to do that. And so that's been really nice. I'll say I'm still going through, what are all the classes for health and exercise science undergrads? What are all the classes for our athletic trainers? I'm still trying to absorb all of the material we're teaching. I'm sure there's going to be places, and I've already identified some places I think we could do stuff differently, like adopting a different model for pain experiences and for injury. But luckily, there are faculty members that come to mind that are acutely aware of things that we should be doing differently already. But academia is like, think of it as like a massive corporation with a lot of moving parts. Like, you don't elicit change quickly. You need to go through the appropriate channels. You need to take your time. There's going to be 100 meetings about it. And then eventually, in a couple of years, you're going to notice things being different. So I think if you go into those scenarios and you're like, I'm going to change everything, you're going to burn yourself out, because it's not going to happen at your timeline. Yeah.
The classes that you do teach, I'm curious of the structure, because obviously you do have lanes in which you have to teach certain material and ask certain things, but like, do you go off of a pure like lecture style? Do you keep it super like integrative with questions back and forth, or how have you structured it?
Yeah, so my preference is a conversation. That is my running theme from clinical practice to teaching. So I tell all of them up front, like when I'm going over syllabus on syllabus day, I'm like, my expectations of you are XYZ, and my expectations for myself are XYZ. What expectations do you guys have of me? What are you here for? So on and so forth. So I'm very much a believer in setting expectations appropriately, so we're all on the same page. And I tell them, I'm like, I don't want to be a talking head. Like, you're not going to learn by me being a talking head. You may learn some material you can regurgitate, but for my folks who want to be clinicians, like, that's just not how clinical practice works. You're not regurgitating information to folks. You're working with humans. So you need to have conversations with them. And so I try to elicit as much conversation as I can. I'll ask open-ended questions. I'll poll them. I talk to them about other things that aren't related to school to get to know them. The nice thing about Bridgewater is, so when I taught at JMU, I had classes of 90 students, and then I would have 2 GAs. And so like the odds of me getting to know you in a 90-person class are extremely slim. Like I would have students come talk to me and ask me a question after class, and I would have to lead halfway through the semester asking them their name, because there was just no way I could memorize everyone's name. Bridgewater, my average class, I think my sports nutrition class is the most full, and I think I have 25 students. So it's much easier for me to know who am I talking to. The advising component of my job is awesome because I have 20 students that I have to advise, and they're with me for their career at Bridgewater or their amount of time at Bridgewater. So I have a direct line of communication with them. They know they can come talk to me about anything if it's not school related, and I get to directly work with them. And I think that's probably one of the best ways to get faculty members kind of integrated into the student body. And then just going out and attending events, going to see them play sports, or going to be a part of student body things. So I try to attend as many things as I can at the school level as well.
That like conversation based class environment, does it ever, do you feel like there's always participation, or is it always like the 2 or 3 students that always talk and then the rest just don't say anything?
So I'm only a weekend, but this
Oh, got
week, we just started back. So, well, I'll take it back. When I taught adjunct for them last semester, it was harder because I was hybrid. So I had students in the classroom and I had students on Zoom, and I was trying to bounce between both of those, which is not fun. And it was a lot of stress. So I would wager that my ability to teach at the level I would hope for myself was not there. Any more than their ability to be the level of students they want to be also probably was not there. So one of our big kind of mantras for the entire faculty body right now is just trying to be human and having, forgiveness for one another, as far as like our expectations not being as high as they used to be in prior years. But so far, like for this group this semester, they've been very engaging. And, I think you have to have a bit of vulnerability as an educator and willing to have conversations with people, because there's a solid chance someone's going to say something, you're going to say something wrong, or they're going to be able to call you out on it, or there has to be a level, and this goes for clinicians as well, like you have to have a level of vulnerability to do these things. And if you try to like have this barrier up in front of yourself as the all-knowing being, I don't think that's going to work out well. Nicole Piamani's book comes to mind on Afflicted, and she talks a lot about vulnerability being the kind of variable that we need to heal healthcare from the clinical side. And I totally agree with that. And I think the same could be said from educators. There's a underlying like pedagogical conversation to be had here about, in America, our system of education is you pay me money, I deposit knowledge in your mind. And to me, a better approach is this active component of learning, not you gave me money, I give you knowledge. And with the same could be said for clinical practice.
Mark, you're in the AT program, right?
So I'm like a hybrid role. I'm technically an assistant professor in health and human sciences. So I teach health and exercise science undergrads, but then I teach grad athletic trainers.
Okay, I was just wondering, from the athletic training side, because I know they have national boards, right? Do
Yes.
you have the same pressure to teach to the test to make sure that you have a rate of passing so that you can market appropriately to grow the university? Just because I see that within the PT world, and I'm just wondering whether or not the AT world has that same type of drive.
Yeah, that's what I'm slowly like getting a pulse on, getting a reading on, is seeing. So example, I have a lab on campus just below my office, but I share it with other professors, and so we were walking through it, and I saw an old I think it was a fluidotherapy machine for it, right? Yeah, and the thing was like yellow. You could tell it's from like the late 70s, early 80s, and I'm like, why do we also had a diathermy unit, and I'm like, what the hell is this stuff? there are standards, right? So like your accrediting agency will come in and say, I want to see an ultrasound machine, I want to see an e-stim machine, I want to see the fluorotherapy. And so you have to have that if you're going to be an accredited institution. So the question then becomes like, okay, they're going to force us to teach this material. My thing then is, how do I teach it? And I'm fully comfortable with saying, hey, this is some bullshit you're going to have to know on the boards. We're going to learn it, moving on, right? I don't have an issue with that at all.
I think that's perfect. I really do. I think more professors need that honesty of, look, I'm teaching to the boards. We need to know the shit just so you can pass the boards. But in clinical practice, this is bullshit and you're probably never going to fucking use it. Or if you do, it's going to be the one-off where the patient's like, this cured me last time. And so you're going to just meet them where they are and you're going to throw this shit out.
Right.
You can even turn the machine off and still have it and they're going
Doesn't
to
matter.
Right,
Yeah.
exactly. So I think that there is a need for some of that, but how do you foresee or how do you hope to influence and change that when
Yeah.
we know that we don't? I've written questions for the PT National Board. I've yet to have one accepted simply because I think that they're not looking for real questions. They're looking for, the same shit that they've always had. So
Old guard stuff.
yes. And so how do we go about changing some of this narrative of, well, I'm going to pass the boards and so I'm going to have this, and how do we change the accrediting so that we're not having some of this old shit that's there, because we're always 20, 30 years behind and what the accrediting agencies and what the board is looking for as far as their test taking. And I know that's way outside of what our general talk is, but
No, you're fine.
an educator now, I'm interested in your thought process.
Yeah, that was like, I had to do a couple of interviews because you're adjunct, like you don't just suddenly become an assistant professor. So I had to go through levels of interviews and I had to be interviewed by other faculty. And the big question kept coming up is like, why are you doing this? Like you have multiple other, ventures that you're working on. And I'm going to answer your questions why I'm bringing this up is it's because I felt as though the next step to have a broader influence is entering into academia. So having the ability to influence how are we teaching our courses. The next step will be policy level, which is ultimately where I think we make long-term changes. Like I have to help place new constraints on the system. So one way to do this is I have a friend at University of Pittsburgh, UPMC, Jim Eubanks, who's a PMR physician. And he and I have had this conversation multiple times. And way the UPMC functions is they have their own standalone healthcare system and insurance system, right, for folks specifically in the Pittsburgh area. And so what they can do is, as a subscriber to that, they can then look at the data and say, you know what, no supportive data for acupuncture and dry needling, we're not paying out on it. And what happens is you watch the clinicians using dry needling and acupuncture plummet. There's a top-down change. So I think like what we're all talking about and what we're all advocating for is bottom-up change. And I absolutely 100% think that's important. But I think we also need very strong top-down change, placing constraints on the system.
Oh, without a doubt, the only way I really see the change happening universal is a top down. We can all drive individual change, and we should, within our scope, do what we can do within our practices or within our circle of influence. But the only way that we have broader changes is really to drive from the top down, whether that be payment, whether that be policy at the university level, whether that be anything. Right? Now, I'm from where these guys, I graduated many moons ago, where these guys go to school, right? And we had a day with physicians and we were told to show them e-stim, ultrasound, diathermy, all the other bullshit, not actually have conversations about how we can impact people, but show them all the whiz bangs and the warm fuzzies, not anything else. And we had third-year med students come through that were doing that. And I would just try to have a conversation with them. Hey, how would we work together? How would we do this shit? But we were told from the university, this is the shit that you have to show them.
Yeah, I'd have landed in the principal's office that day.
I was called, like I told Chris once, I was called multiple times to the dean's office because of some disparities in our thought process. But it's just, the university has different ethos and different mindset of what they're looking for.
Well, their whole thing is obviously like you have to, it's interesting going from business owner as well into academia, because I see the same kind of operational premise emerge as far as like, this is a business. Like we just went through what's called an SRA. Don't ask me to tell you what the acronym stands for. I don't recall. They've told me multiple times. But we looked to the college, and this was pre-pandemic, but the college looked across the board at enrollment levels in various schools and decided like, yeah, philosophy department, you're not performing, sorry, you're gone. And tenured professors got laid off, which is, as you know, highly unheard of in academia, and departments were dissolved. And I understandably so, fellow faculty are now distrusting of admin, right? Because they're like, well, you're supposed to take care of us. You came in and got rid of our tenured professors. They did it because it's a business. And if you didn't, unfortunately, take away the parts that weren't producing financially, then the whole university or the whole college goes under. And you're not going to let that happen. And so you have to accept on some level, you've got to play the game. I think the ethical question for each individual is like, how comfortable am I playing this game? And do I have very designated lines I'm not willing to cross? And I think that's a very individual question.
But isn't that what emeritus status or whatever it is? I mean, they're a professor, but they're really not. They come on campus, have a little office, and they're really not producing. And they just add some, maybe some grant or some gravitas if they have a Nobel or some other kind of shit to the university. But otherwise, they're really not doing anything at the university. We had many of those at UT, and you know, I mean, they really weren't producing, but they add some gravitas, or they can help with a grant getting passed.
Yeah, they had clout. I get it. I had our media department reach out to me this past week asking me what I had that was newsworthy for the college, right? And that has nothing to do with like they're interested in my research, but everything to do with, can we play up your research to market our college? You know, that's, and so you have to just like play. I thought about this when I got the email. I was like, I could just be like, yeah, fuck off, whatever. But no, you say, well, yeah, this is the research I'm conducting, and you have to be a bit of a salesman. Now, luckily, I come from a business background as well, with owning, my wife and I both owning multiple businesses. And so I get the game, but I could totally see how, if you're coming from a pure academic background, that you're like, I'm not here to sell anything. That's not my job. My job is academia and education. So
yeah, for full clarity, both my brother and sister are in academia. They're both PhDs. They teach at universities. They do all that stuff, and we all have these conversations. And I tell them how it's just a big fucking business. You're not really educating students.
It is
trying to do this shit, right? And we have these discussions all the time. So for full transparency, I have two family members that are in higher education, and I tell them what a shill game it is more than once a year. So.
Yeah, before I got into this, the people who pushed me to do it, both of them are professors that are friends of mine for multiple years. One I mentioned already, Dr. Keller, and the other is Dr. Sam Hamilton, who's an English professor and heads up their Masters in Media Arts program. And they would say things to me about me doing stuff for Barbell Medicine, and they would say, well, you're a business, your primary premise is financial gain, to which I would say, and you think yours isn't? Like, your whole job is predicated on financial gain for the college, right? And you're accepting financial gain in return for doing that for them. So we all find ourselves in a capitalistic society. That's the nature of the beast. But I think it's perfectly okay to be like, you know, I'm not comfortable with that, or having ethics. Ultimately, if I zoom out and try to think about the societal influence, I think the college or university sets the ethical standard, right? As far as like, what are we comfortable with doing, and what are we having comfortableness with having our faculty and staff members doing? And if you're not at a university that kind of prioritizes some type of morality level, probably can find yourself in all sorts of things.
Just like, you know, if you've read the book Conscious Capitalism, there's capitalism that's just raw, unfettered, right? And then there's conscious, right? Are we conscious in our application of what we're doing, and how we can impact and yet still make money, versus how we can just make as much money as possible? There's different ways to go about making money and still doing that. Just like as in a business, we can run a business, right, and still have impact, or we can just run a business and we can do a shit job of having impact and just make the money. The choice
I've not read
of individuals, and oftentimes we have a short-term gain for the increase in money, but we have a short-term gain, right? If we're playing the long game, you have to still make impact within people's lives, or you're not going to be viable long-term.
I was making a note. I've not read that book, but it sounds pretty in line with like my thinking about it, for sure. Conscious capitalism. So I'll have to read it. But yeah, so people ask me all the time, they're like, well, your model of clinical practice doesn't sound like it affords you the ability to see 20 patients a day. And I'm like, you're right, it doesn't. They're like, well, how do you survive? And I'm like, I'm not looking at it from a week to week survival. I'm looking at it a year to year survival. And so I think if you learn, it's just like any investment in life. If you learn to take a lower risk with a sustainable yield versus a high risk, high initial yield, you're going to be better off 20, 30 years down the road. And so that's the same
Well,
mindset I try to bring to
just like
practice.
lifting, right?
Yes,
If I try to
exactly.
hit 400 and I've benching 200 now and I just rush towards that, I'm going to blow up somewhere along the way. It's not sustainable training, right? We have to have this
Yep.
long-term view of training, or we get caught in that injury cycle and we never actually achieve shit long-term.
Yep.
Right. And so we have to have that same kind of model long-term business wise. It's just many don't, unfortunately, and they just play the short-term game.
Yeah, which is where all those modalities come into it, right? Like, what can I bought the $60,000 class 4 laser. I need to recoup all of that now, so I'm going to afford it to my patients, right? It's
Exactly.
a short game.
Yeah.
All right, Michael, I know you wanted to head out at 12:30, so I appreciate you being able to chat for 90 minutes, and this has been great. I'm glad it kind of like went in multiple directions.
Yeah, man, I enjoyed it. Thank you guys for having me. If you ever have any questions, you can email me. You're not going to bother me. Just mike@barbellmedicine.com. I'm happy to talk.
Perfect. Thank you so much. All right, everyone, enjoy the rest of your Saturday. Bye.
Bye, guys.